When we were considering the launch of JPAL North America, all of us as directors are development economists, and we realized that we didn't have the credibility or the knowledge to launch JPAL North America or lead it ourselves. We needed someone who had a reputation, a sterling reputation in the academic community, who cared deeply about poverty and about what good quality evidence could do to improve the effectiveness of policy. We also needed someone who could build a coalition of researchers around them. We were extraordinarily lucky that Amy Finkelstein and Larry, who's a professor here at MIT, and Larry Katz, a professor at Harvard, agreed to take on the challenge. We could not have found two more qualified people. Please join me in welcoming Amy Finkelstein.
Thank you very much, Rachel, and I'm thrilled to be here. We've had a wonderful day so far hearing about what randomized evaluations have accomplished in developing countries, and as Rachel said, I'm here as the representative of the new kid on the JPAL block, JPAL North America, which I just launched this fall together with Larry Katz at Harvard. And we're hoping to improve the domestic evidence base and policy discussion the way JPAL has had such success internationally. So what I wanted to talk to you about today is some of my own experiences working on a particular randomized evaluation of health insurance in the United States, some of the reactions to it, and how this inspired me to co-found JPAL North America to try to get more of these types of randomized evaluations done. So there's an active and at times quite heated debate in US policy about the impact of expanding health insurance. And this is particularly true when it comes to expanding Medicaid, which is the public health insurance for low-income individuals in the United States, low-income elderly, low-income adults, and low-income children. The federal and state governments in the United States currently spend about $400 billion a year on Medicaid. And as many of you, I'm sure, know, there's a major expansion of Medicaid planned to start next month under the Affordable Care Act, or Obamacare. And as you can see from this collection of slides, opinions and claims about what the impact of Medicaid will be, or expanding Medicaid, vary enormously. So, on the left, literally as well as on the slide, you have claims that actually, expanding Medicaid is a win-win situation. It's a free lunch because expanding Medicaid will actually save money. If you take low-income uninsured people and provide them with public health insurance, it will improve their health. It will improve the efficiency of their care delivery, getting them into cheaper preventive and primary care and out of the expensive emergency room. So we're going to make people better off and save money, which of course would be wonderful. And then on the right, both on the slide and more figuratively, you have claims that actually Medicaid is useless or worse than useless. It's worse than no coverage at all. And the theory behind this argument goes that, as is well known, reimbursement rates to doctors and hospitals for Medicaid are very, very low. And so providers, it's claimed, are often reluctant to accept Medicaid, so that it may be, in fact, easier to get access to a doctor if you're uninsured and are paying out of pocket, in which case they can charge you a higher rate than if you're paying the low Medicaid rate and you're unable to top it up. So as you can see, there's lots of opinions out there, and there was very little rigorous evidence on this subject. Enter the Oregon health insurance experiment. So Oregon, like many states, has two Medicaid programs. It has the traditional Medicaid program, which has both financial eligibility requirements, you have to be poor, and certain categorical requirements. You have to fit into a category to get Medicaid. You have to be a child or a disabled adult, et cetera. And they also have an expansion program to cover low-income, able-bodied adults who aren't otherwise categorically eligible. So these individuals are all poor, they're below the poverty line, and they may have children, but they're not themselves children, and they're not disabled or on welfare or pregnant. They're 19 to 64-year-old low-income uninsured adults. This program had been closed to new enrollment for several years in Oregon for lack of budget funds. And at the beginning of 2008, the state of Oregon realized that they had funds to cover an additional 10,000 individuals. However, they also correctly realized that there were many more than 10,000 people who would meet the eligibility requirements if they opened up the program. So they got together with their stakeholders and had a conversation and decided that the fairest thing to to do was to run a lottery. So they did a really big public relations campaign and recruitment effort for this lottery. They had 10,000 slots. They had 90,000 people sign up for the lottery in January and February of 2008, and then they literally ran a lottery to select the people who could get Medicaid. Now, some people thought this was funny. So, for example, you have Stephen Colbert on the Colbert Report, did an episode on this lottery where he made jokes about pick snicks, or my favorite, which we couldn't show you the video of for copyright reasons, but he has a little scratch lottery ticket. He's like, ooh, am I gonna get a kidney? Ooh, am I gonna get a kidney, right? So he saw it funny, and I'm not totally humorless either, but I didn't see it as funny. I saw it as an amazing opportunity for research, right? To bring randomized evaluation to studying what's arguably one of the biggest questions in health policy in the United States. What will happen if we expand Medicaid to cover the uninsured? And fortunately, many generous funders agreed with me, and not with Stephen Colbert, including the federal government. So if you drove in on the Mass Pike, you probably saw a sign, and I always think of this as talking about my project, because the Oregon health insurance experiment, like the Mass Pike, was funded by the American Recovery and Reinvestment Act, otherwise known as the stimulus program, because you will remember 2008, 2009 was when we had major stimulus, and we had many other generous funders, including foundations who stepped up early and provided key initial support. And one of the things this allowed us to do was conduct 12,000 in-person interviews and physical health exams to get measures of how health insurance was affecting people on a wide variety of dimensions. So I have to mention that data collection effort led to a few research challenges that my otherwise excellent MIT graduate school education had not prepared me for. So I saw our department chair, Whitney Newey, in the audience as I came up here. He's an econometrician, and I learned from him how to design an experiment so that you had the appropriate sample size and clusters so that your standard errors wouldn't blow up. What he didn't teach me is what to do when my data blew up. So literally, this is true. This is a FedEx truck that had our dried blood spot samples from our our first round of in-person interviews and physical health exams, and this is the photograph that our field manager sent us, right? Your data has blown up, literally. The FedEx truck just exploded outside of our office in Oregon. Now, don't worry, there's a silver lining. I've been called things that probably aren't polite to repeat here, but I think the polite euphemism for it is that I'm known as detail-oriented. And so one of the ways in which me and my research team were detail-oriented is that we had triple shrink-wrapped and packaged these blood samples in many, many layers of packaging. So the punchline is, despite the front of this truck that was blown up, our dried blood samples in the back were quite safe and ultimately got to be analyzed. So using this type of data and a bunch of others that I'll show you, we're engaged in an ongoing effort to study the impact of covering the low-income uninsured with Medicaid on a wide variety of outcomes, including their healthcare use, their financial security or financial strain, and of course, their health outcomes. Now, I'm not gonna have the time to show you all the results. If you go to the JPAL North America website, you can see a link to our study and see the current results, and we'll be coming out with some new ones in about a month. But just to give you a flavor of the results, these show the impact of Medicaid on healthcare use, particularly whether or not you go to the hospital. And this comes from administrative data, so that has several we're fortunate in the United States that there's a rich supply of administrative data which have several advantages. One is you don't have to worry about your FedEx truck blowing up because you're not collecting the data, but the other is that you can get large samples very cheaply and look at a wide variety of outcomes. And so this shows whether or not you went to the hospital in about a one-year period following insurance coverage. The dark blue lines are the control group, and the light blue shows the increased effect due to Medicaid. And so what you can see is that on average, in about a one-year period, a little over 6% of our sample goes to the hospital in a year, right? So these are people 19 to 64, and I should mention we've excluded childbirth, right? And what you can see is that covering them with Medicaid increases that by about 2 percentage points or 30%. A lot of this coming through hospitalizations that don't go via the emergency department, that may be less severe and therefore less price sensitive. So as I said, we have a whole variety of results. Just to give you a brief overview, we found that Medicaid increases healthcare use, including preventive care. It increases annual spending by about 25%. It reduces financial hardship, including virtually eliminating the risk of what's called catastrophic out-of-pocket medical expenditures. Those are more than 30% of your household income. We had a 30% reduction in the probability you screen positive for depression. We found no statistically significant improvement in measured physical health, like your blood pressure, your blood cholesterol, or your blood sugar. And we found no statistically significant effect on people's employment or earnings, which is something that in the United States there's a lot active debate about on both sides. Now, there's been a tremendous media response to this study, despite there being a lot of previous work on this topic, all of which, of course, was non-randomized. And I think that points to the credibility and power of randomized evaluations to affect, to get out beyond the academy and into the real world. And you'll note here something very interesting. These are just a sampling of headlines. And they say everything from Oregon's lesson to the nation, Medicaid works, and then the article goes on to talk about reductions in depression and reductions in exposure to major financial risk, to spending on Medicaid doesn't actually help the poor, and those articles talk about how we didn't find statistically significant improvements in physical health. But what's really gratifying to me about these headlines, which I've never seen in a non-randomized evaluation, is no one's arguing about whether what we found was a real result. No one's saying there's something wrong with our inference. They're arguing about what it means, right? Which I think, again, really speaks to the power and credibility of randomized trials to get out of just the seminar room, back in E52, about, did we actually find something, and the entire public can accept that we found something and engage with what it means. I also think as a result, it's had some impact in reframing the debate in a positive way. So while of course, there always are going to be people making far-fetched claims on either sides, a lot of the discourse has moved on to actually grappling with the results. And I just want to give you a sample of 3 headlines from the New York Times sort of series of opinion page articles on this study. So one came out and said, well, grappling sort of the conscience of the liberal, why should we expand care if it has no proven benefits? This was again talking about the lack of any improvements in health. And then Paul Krugman comes back with the conscience of the liberal saying, by the same token, do we think fire insurance is worthless if it doesn't put out fires? Let's not forget, guys, that the point of insurance is not necessarily to improve your health, but to protect you financially against catastrophic out-of-pocket medical expenditures, and that's what it's doing. And then you have Russ Douthat coming back and making, I think, the very interesting and reasonable point. Well, if that's the point of health insurance, if health insurance is a financial protection instrument, why don't we have catastrophic health insurance with very high deductibles where you pay a lot at first and less later, which is a very good, as opposed to first dollar coverage, which is a very good question and precisely why we need more experiments to answer those and other kinds of questions coming out of this. And this is why, together with Larry Katz, we founded JPAL North America to be much broader than just health, to try and bring this kind of randomized evaluation where, thanks to generous funding from the Sloan Foundation and the Laura and John Arnold Foundation, we're already funding new randomized trials. We've embedded a new JPAL North America member of our policy team in the social and behavioral sciences team in the White House that's encouraging randomized trials. And we're here to promote them in any way we possibly can, and we will figure out someday a way to make sure that our FedEx trucks also don't explode. So thank you very much.